Hi everybody, I am Dr. Pradeep Kumar Shenoy, consultant rheumatologist at Amrita Multispecialty Clinic, Attawar. This is the first rheumatology clinic of Dakshina Kannada and Udupi district in Karnataka. In this video, we will succinctly look into steroids. Steroids are called as corticosteroids because they are synthesized and secreted from adrenal cortex. They are also called as glucocorticoids because of their ability to increase blood sugars. Steroids can mobilize amino acids from the muscles and mobilize it into the liver, and they can synthesize glucose from the amino acids. They can also bring forth glycogenolysis, and glucose can be secreted from the liver to the blood. They also inhibit the secretion of insulin from the pancreas. So these are the three mechanisms by which steroids increase the blood glucose. So they are called as glucocorticoids. The least possible dose of steroid with anti-inflammatory and immunomodulatory effect is 7.5 milligram of prednisolone equivalent per day. So we will look into the anti-inflammatory and immunomodulatory potency of all the steroids. If you consider the potency of cortisone as 1, 4 milligram, 4 is methylprednisolone, 5 is prednisolone, 6 is deflazacort, 20 is hydrocortisone, zero point 0.6 is dexamethasone, and zero point 0.8 is betamethasone. And apart from this, steroids can have hypertension. First, what I mentioned is hyperglycemia. So, if the patient is having hyperglycemia after consuming steroids, we use oral hypoglycemic agents to bring the sugars down. If it is not controlled, then we use insulin. And as I mentioned, because of the fluid retention and sodium retention properties of steroids, there can be hypertension. In this case, we use antihypertensive to control the blood sugars. Steroids can also produce osteoporosis by mobilizing calcium from the bone or by excreting calcium in the urine. This can stimulate parathyroid, and it ultimately can produce osteoporosis. This is prevented by giving 1500 milligram per day of calcium and 400 international units of vitamin D and bisphosphonates. And there are other ways to minimize the side effects of glucocorticoids or steroids. One is to start with the least possible dose of steroid, then slowly increase the dose of steroid depending upon the disease activity. Then, once the disease is in remission, maintain the disease remission for adequate duration as per the nature and activity of the illness. Then, slowly taper the dose of steroid and stop it. This is one method. Second method is to start glucocorticoids and steroid sparing agents simultaneously. Steroid sparing agents also have an inhibitory effect on the pathogenesis of the illness, but they take time to act. But if you start steroid sparing agents and steroids together, the disease remission is induced much faster. So once a remission is induced, this combination is maintained such that the remission is maintained for adequate duration depending upon the nature of the illness. And once the remission is maintained for adequate duration, the steroid is slowly tapered and maintained at a dose of 7.5 milligram along with the steroid sparing agent for 2 years. And high dose of steroids in rheumatology is offered only when there is a crescentic glomerulonephritis of vaginous granulomatosis, or if there is a Goodpasture syndrome with lung and kidney involvement. At that time, rheumatologist will offer you high dose of, rather very high dose of steroids. And if you think about the side effect of the steroids and develop cold feet, and if you deny the steroids, then probably your life as well as quality of life is in danger. So, in such conditions, you accept the steroids wholeheartedly, tie over the crisis. Once you tie over the crisis, we will help you in going forward with your personal life, professional life, and personal life successfully. That is what we are trained for. In this venture, I would like to thank Philip Showalter Hench and Edward Calvin Kental, whom I consider as father of steroids.